Welcome to the definition and classifications of arrhythmias. So this is where we start looking at differences in electrical activity. Arrhythmia, by definition, is the lack of rhythm or an irregularity in the pattern of the heartbeat. So it's an irregularity in the pattern of the heartbeat. So the rhythm of the heart may still be regular, but there's irregularity in the pattern. So the rhythm could still be regular, but the rhythm, or it could still be irregular. So when this, arrhythmia refers to all the variations from a normal heartbeat. So this variation could be from the rhythm. So is it a regular rhythm? In other words, 5 boxes in between R waves. So is the rhythm regular, or is it irregular, where there's 5 boxes between R waves, 3 boxes between R waves on the next series, 2 boxes in the next series, 5 boxes in the next series, so on and so forth. Is the rhythm regular? The next one's going to be rate. So rhythm is the first one. Rate, it would be the second one. Is the heart rate too fast, or is the heart rate too slow? When we can be looking at atrial rate or ventricular rate here. So rhythm, rate, and then finally conduction is that last area there. Is the conduction normal through the heart? Do we see a slower or faster conduction? So normal through the heart. So typically classified and named according to the site of origin or the type of cardiac activity that's produced through it. So the site of origin is the heart structure or structures. So where do they begin? Is this an atrial issue or a ventricular issue? Right? Is it not enough activity, or is it too much activity when we're looking at the cardiac activity? Potential sites of origin, of course, all the nodes, so SA, AV, bundle of his, Purkinje, so on and so forth. The ectopic sites in the atrium ventricular muscle fibers, so supraventricular, which would be an ectopic site. So that's something causing irritation or electrical conduction going through those. So classification system. So let's start here. Bradycardia would be a slow heart rate, less than 60 beats per minute on an adult, less than 60 beats per minute on an adult. A tachycardia would be a rapid heart rate greater than 100 on an adult. Greater than 100 on an adult. The classification system, you have premature beats that are cardiac depolarization and contraction occurring earlier than expected in the cardiac cycle. So we're looking at premature ventricular contractions or premature atrial contractions. That's where the contractions of either the atria or the ventricle happen prematurely than what was expected to happen. So flutter is one of the first ones we'll look at. This is where you have that classic P wave sawtooth pattern like you see here. Fibrillation is just like when someone lies, they're all over the place and it's unpredictable, right? So that's where fibrillation comes into play. Sawtooth pattern is flutter. Fibrillation is all over the place. So flutter means you have regular, repetitive, occurring at extremely fast rates. Fibrillation means you have an erratic, quivering, twitching of the muscle. So it's highly irregular. So fibrillation would be irregular. Flutter would be a regularity because there's uniformity to it. Fibrillation, there's no regularity. It's irregular. It's erratic. It's all over the place. It's just a quivering atria. It doesn't really have any order. It is just pure. Heart blocks. Heart blocks, usually we're looking at a delayed passage or complete block of cardiac impulses at the AV node area. In other words, SAAV node, their communication is very, very poor. So this may be classic according to the seriousness. So some of the minor classifications would be atrial fibrillation, atrial flutter. They're pretty minor. They're not life-threatening most of the time. Major would be heart blocks, so type 1, type 2, type 3. Those would be some of the major issues with some of the arrhythmias. And then finally, there's death-producing ones. This would be things like pulseless electrical activity, also known as PEA, asystole, which means no electrical activity is going on, ventricular tachycardia, and ventricular fibrillation. Those are death-producing. So pulseless electrical activity, asystole, ventricular tachycardia, or ventricular fibrillation. So PEA, asystole, VTAC, and VFib are the short versions of those. A 5-lead EKG is just your typical monitor to help in arrhythmia recognition, just basic arrhythmia recognition. It is not near as diagnostic as a 12-lead. A 12-lead EKG looks closer to see at other problems, and it can see it in a more way. So a 12-lead EKG, if the 5-lead is abnormal, then that's usually an indication for a 12-lead. So when do we do this? The normal EKG, the electrical activity of the heart is under control of the SA node, and when normal PQRST complexes can be seen to occur regularly, the heart rate should be 60 to 100. The heart rate is said to be in normal sinus rhythm. So if we have a SA node that's controlling it, and we have normal PQRST complexes, and they occur regularly, and the rate's between 60 and 100, this is normal sinus rhythm. You might see this written down as NSR, normal sinus. Sinus tachycardia, the sinus node may be send out impulses at a faster than normal rate, producing a sinus tachycardia. So that means the SA node wants to go fast. Let's just say this is almost like someone gave the SA node a little bit too much coffee. Some more caffeine. Sinus tachycardia is characterized by rapid firing of the sinus node at a rate of 60 to 160, rate of 100 to 160 times or more a minute. So rate of 100 to 160 times or more per minute. Fast rate. Sinus tachycardia has cardiac depolarizations and contractions. It will have a normal sequence. It differs from normal sinus rhythm only in the rate. In other words, everything else looks normal except for the rate is 100 to 160 times. The normal PQRST complexes are usually seen, so you'll have everything there. They're just going to be closer together. So closer together is what you'll see with our QRS complexes. They're smushed together because the heart's going really fast. It's a sinus tachycardia. These are usually not a rapid onset. Patient might be unaware that they're in a sinus tachycardia. Also, sometimes it can be pretty minor. The description of a sinus tachycardia will have a P for every QRS wave. We'll have a regular rhythm, so the R to Rs will still be pretty regular. In other words, 2 boxes, 2 boxes, 2 boxes, 2 boxes, 2 boxes, 2 boxes, right? And so you'll have a regular R to R. There won't be variation where you'll have an R to R that's 2 boxes, and the next one will be 1 box, and the next one will be 2 boxes, and the next one will be a half of a box, right? So there'll be a regular rhythm to the R to R interval. And the rate will, of course, be 160. Occasionally, when the rate of the sinus tachycardia becomes very rapid, the P and the T waves may overlap. In other words, the P and the T waves will sort of be hidden together Sort of looks like, and hopefully you can look at that rhythm in a little while. The big causes of a sinus tachycardia: fever, right, making the heart work harder; sepsis, that blood infection that makes your heart work harder; hypoxemia, so your heart's trying to pump harder to get more oxygen to your body; congestive heart failure, because your heart's not squeezing strong enough, it's trying to compensate with the cardiac output by going faster, which would be the sinus tachycardia; shock, your blood vessels, well, depending which type of shock you're in, it's going to be hard for you to get circulation, so your heart would have to beat faster to try to get your circulation back on board again. If you're scared, right? This is your tachycardia before an exam, especially during this whole thing. And finally, exercise, my favorite cause of sinus tachycardia. It's a known scenario there. Usually represents a normal physiological mechanism, and it's very benign. In other words, it's not something that we're really worried about unless it causes some severe side effects if they have a heart defect to begin with. So it's very benign. It's considered a minor arrhythmia. In other words, it's not life-threatening. Greatest significance may be a signal to underlying disorders like hypoxemia, sepsis, so on and so forth. So when you see a sinus tachycardia, that usually tells us something deeper could be going on. So let's check their vitals. Let's see what else is going on. The greatest significance may be a signal to other underlying disorders. So that's usually a flag in their vitals. Like if they have a sinus tach, then we need to look at what could be causing that sinus tach. So when can this be dangerous? So the patient that already has a weak heart, like let's say they're in congestive heart failure, they cannot take the extra workload of the heart going faster. And so not only will their heart go faster and expend more energy, but they didn't have enough energy or strength to squeeze the muscle in the first place. And now we're stressing the heart even more. So let's say someone that's in heart failure gets a round of epinephrine. So what will happen to the heart rate? Well, the heart rate's going to increase really, really fast. And was their heart muscle strong enough to begin with? So that's where a sinus tachycardia actually could be dangerous, right? If a patient already has a weak heart, they can't take the extra workload of a sinus tachycardia, so they could be very unstable. The key treatment is to determine the underlying cause. Is it hypoxemia? Is it acidosis? Is it sepsis? Is it so on and so forth, right? So we need to figure out why they're in a sinus tachycardia. Sinus brady, this is almost the complete opposite. This is produced when the sinus node initiates the electrical impulse at a rate lower than 60. So a rate slower or lower, it would be a sinus bradycardia. Characteristically, the rate ranges from 40 to 60 beats per minute, but slower rates can be possible, but 40 to 60 is your primary here. Cardiac depolarization and contraction will occur in a same and orderly sequence. In other words, there will be the same number of boxes in between the R waves and so on and so forth. The PQRS complexes and the PQRS intervals will occur at wider distances. So instead of 2 boxes like you would see in a sinus tach for an R to R, you would see a lot more boxes in between those R to R. But they would be roughly the same. So here you see in this picture that distance, a lot wider distance. So for every P, you will have a QRS complex. So that's a good sign. That means it's coming from the atria. You'll have a regular rhythm. In other words, the R to Rs will have the same amount of boxes. So when we're counting R to Rs, 5 boxes, 5 boxes, 5 boxes, so on and so forth. So your rate's going to be roughly around 40 to 60 for that sinus bradycardia. Causes of sinus bradycardia. Well, coronary artery disease is one of the first ones on here. North America, you're probably going to see some of this out there. Coronary artery disease is one of the big ones that we have, usually associated with chronic hypertension or chronic high blood pressure. An increased intracranial pressure One of the classic signs of a neuro patient, their blood pressure will increase and their heart rate will decrease. This is called a Cushing reflex. So you might see a sinus brady with an increased intracranial pressure. So there's swelling in the brain. They might have a Cushing reflex where their blood pressure increases, and because their blood pressure is increasing, the body's trying to regulate it by slowing the heart rate down. Hypothyroidism can also cause a sinus brady. This is where you have a low metabolism. These people usually have a lot of be very lethargic, very fatigued very easily. They'll have very cold extremities or cold all the time. That's one of those hypothyroidism issues. Digitalis. This is a drug that slows the heart rate and increases the contraction of the muscle. So someone is given digitalis, this will actually slow down the heart rate and increase the contraction of the muscle. So that's actually a cause, is if they get that medication. Athletes, the heart becomes very conditioned, so do their blood vessels become very conditioned, and therefore they don't need 60 beats per minute to have a normal perfusion. They can survive on 40 beats per minute or 50 beats per minute and still be just fine. It's very benign in those patients. Vagal stimulation, so someone that bears down, anything that does that Valsalva maneuver, any type of vagal stimulation, that will cause a sinus bradycardia. That's what you see where people pass out, that vasovagal stimulation. They're on the toilet. That's that stimulation, that vagal, that bradying down. Propanolol is a drug. It's a beta blocker. Any drug that ends in a lol is a beta blocker, and it blocks the effects of the heart rate, and it can actually block the effects of epinephrine too. So propanolol, if it ends in a lol, it's beta blocker. So if they're on a drug, if you look through their medication that they have and they're on a LOL drug, it's a beta blocker and it will slow down the heart rate. If they have a heart block, you might see this on the 12 lead as well, besides just the bradycardia. That would easily cause the heart rate to slow down because the conduction is slowed. Hypoxemia, that's something we always worry about with any cardiac conditions. Is the heart sick because they don't have the heart muscle doesn't have the oxygen to go through it? And then also, rest or sleep can be a big issue here as well. When people sleep, their heart rate should obviously, and if they don't, obviously, it will vary as well. Sinus bradycardia may serve clinical importance as a symptom of other disease processes. So if they have sinus bradycardia with other things, that could be significant. In itself, if it's just that and they don't have any other symptoms going on, it could be completely harmless. They might be just a really good athlete. I remember having a 14-year-old kid that ran track, and his heart rate was in the 50s, and he was just fine. The alarms and the monitors just kept going off every once in a while because he had a slow heart rate, but no symptoms, just good conditioning. So in itself is normally harmless, but when it can be dangerous is when it's excessively so. Now we're talking about heart rates less than 40. If their blood pressure is low, so not enough cardiac output. If they're faint pretty easily, if they're very, if their level of conscious is very poor, in other words, they seem sleepy, they're not responding well, those are signs that this can be pretty dangerous. In other words, their perfusion has decreased where they're not able to compensate for it. So sinus bradycardia may be dangerous for the patient with an MI. Because that slows the conduction and therefore decreases the amount of blood that can be squeezed out. It can be irritable or ectopic sites in the atria that have ample time to fire and take over as the pacemaker of the heart. So irritable and ectopic sites. Treatment of the sinus bradycardia, you're going to treat if they're only symptomatic. So treat if they're symptomatic only. So in other words, they have a low blood pressure, they have a low level of conscious, they have a poor pulse, they have pale, cold, weak extremities, right? So if they're showing signs and symptoms that this is not causing adequate perfusion, then that's when we would treat it. So if they're symptomatic only. So if we have a healthy athlete, a 14-year-old that's talking to you and joking around, I'm not going to worry about their heart rate being slow. If we have that same kid, barely awake, cold, weak, cold, pale extremities, poor pulse, right? Those are all signs that this kid could have a symptomatic bradycardia. So one of the drugs that we can give is atropine. Atropine will increase heart rate, especially. That's one of the drugs they can give for symptomatic bradycardia. We could also do what's called transcutaneous pacing. We'll put pacing pads on a patient's chest, and we'll give electrical impulses just to sort of get that heart rate back up there. We could also give them a drug called dopamine, which will increase the strength of contraction as well. Epinephrine, a good old friend epinephrine there, will increase the speed and contraction of the heart. And isoproterenol is a beta-1 agonist that will increase both heart rate and blood pressure. So all those are options. If atropine doesn't work, or if we have the pacer out, we can use the transcatheter pacer. All the EKG, not the EKG machines, all the machines, the Zoll monitors that you use to connect a patient to with pads like the AEDs, all those machines in the hospital usually have a pacing option on them. So atropine blocks the influence of the vagus nerve on the sinus node. So this permits the sinus node to go faster, right? It says, I'm not listening to the vagus nerve anymore, which slows everything down, right? It's your decreased, relaxed nerve, right? That's that nerve that decreases your blood pressure, decreases your heart rate, that smooths all that down. Well, now you're saying, I'm not going to listen to that anymore. I'm going to let the SA node do its own thing. So when atropine is given, it permits the SA node to move faster. It's to that vagal stimulation, whatever's causing that vagal stimulation. A sinus arrhythmia, and notice it says sinus arrhythmia, when the sinus node demonstrates a quick basic quickening or a slowing of impulse information. So basic quickening or slowing of impulse formation. So this can happen with your normal breathing cycle. That's why you see that picture. This can be an irregular rhythm where you see the heart rate speed up when they're breathing in and slow down when someone's breathing out. So you see the lungs inflated and the heart rate's faster, and the heart rate's slower when they're breathing out. So this is an irregular rhythm. It can happen with breathing. It generally coordinates with the respiratory cycles. The heart rate usually will increase with inhalation and exhalation. Sinus arrhythmias, cardiac depolarization and contractions usually will happen in a normal and orderly sequence. Normal and orderly sequence. For every P, there'll be a QRS complex. They will be at normal intervals. So only now these processes occur at irregular intervals, with the sinus node alternately sending out impulses quickly and slowly. So the sinus node, or the SA node, now can't make up its mind if it wants to go fast or slow. Fast or slow. It can't make up its mind, right? This is what we see. We have a normal sequence of PQRS complexes. Usually we'll have normal intervals, but it's the initiation of the heart rate that will vary between. So this differs from normal sinus rhythm only by its irregular rhythm. So you'll see faster, slower, faster, slower, faster, slower. This may be coupled with either fast or slow heart rate. And it has no clinical significance. In other words, it means nothing. It can be seen in very healthy individuals. So if you ever told you had a sinus arrhythmia, it means ultimately nothing. It's more common in your generationally advanced or your very, very young